I will go ahead and invite our next speaker, Dr. Fabio Taccone and Ilaria Crippa, who've been kind enough, despite their clinical duties, in joining us. And they will give us a little kind of non-traditional perspective where TCDs have not quite been used as often as they need to be in different kind of encephalopathies, and how we can use that to evaluate these patients' risk of neurological vulnerability as well as target for therapy.
Hello, everyone. Just give me a few seconds to share my PowerPoint. I think this might be the way. Okay. Okay, so everyone can see it, I hope.
Yes.
So I already introduced myself, but for the ones who were online yet, I'm Ilaria Crippa. I completed my PhD at Erasmus Hospital in Belgium under the supervision of Fabio Taccone. And I mostly studied the application of transcranial Doppler, transcranial ultrasound in sepsis-associated encephalopathy. So during my PhD, I have the chance to study how the brain is affected by septic episodes in critically ill patients. And I also had the chance to imagine how we could implement the use of intracranial ultrasound to improve the care of septic critically ill patients. And also understood that there is still much to investigate on the topic. So first thing, it is important to keep in mind that brain symptoms during sepsis are common, and their development involves a number of factors. Hypoperfusion has been established as a major contributing factor. Indeed, the first hint about hypoperfusion as a contributing factor was in the early 90s. So we are talking about hypotension associated with brain dysfunction during sepsis from the early 90s. And later on, but also we are talking 20 years ago, we had confirmations from post-mortem studies that identified area of ischemia in the brain of patients who died from septic shock. So the idea was to use transcranial Doppler to investigate brain during sepsis. But what do we actually expect to see when we put a probe on the skull of septic patients? Well, a number of parameters have been investigated, as you can see in this slide. Let me change the slide. Okay. Given that intracranial vascular system is a low resistance system, we could use, for example, the ratio between the end systolic velocity and the peak systolic velocity as a guide to suspect hypoperfusion. So, for example, if we find that end systolic velocity less than 50% of peak systolic velocity in clinical practice, we can consider, among other parameters, of course, if there's the need of a systemic hemodynamic optimization, even if the mean arterial pressure seems just fine according to the current guidelines, because maybe we have a mean arterial pressure above 65 millimeters of mercury. Also, for example, we know from previous studies that early increase in the PI, the pulsatility index, is associated with later development of sepsis-associated encephalopathy. So, if we find this alteration in one of our patients, we will monitor neurological status very, very close. Also, the problem is that all these parameters are affected by a number of external factors. So, for example, gender, age, or also the respiratory settings. So, for example, some respiratory settings of patients mechanically ventilated can be extreme, for example, due to the need of protective ventilation. And all these external factors, also the vasoplegia involved in sepsis, all these external factors can affect the parameters that we are assessing by transcranial ultrasound. Cerebral autoregulation is probably the the aspect that has been studied most extensively. We know about that it's frequently altered, that the early alteration is predictive of sepsis-associated encephalopathy, and combining this with the idea of the optimal mean arterial pressure can lead to an individualized hemodynamic management of the patient. So we'll see later on what is the optimal mean arterial pressure. Okay, so what's the problem here? The problem is that definite data are lacking. This is a review, it's recent, it's from 2024, and this review summarizes the most relevant questions that are still waiting for an answer on brain perfusion. So, for example, is brain perfusion altered in sepsis? If so, how? And can we use ultrasound to guide sepsis resuscitation? Or can we use ultrasound to predict the neurological outcome of patients? Like $1 million questions. What I found really interesting about this review, even if I already knew, but is that no trial were found to be included. No, the 34 studies included for data extraction were for the 85% observational studies and then 50% of systematic reviews with or without meta-analysis. So we really need robust data on this topic. So considering this general picture, it is very difficult. It has been very difficult, at least until now, to identify specific alteration in brain hemodynamics of septic patients. This is a meta-analysis that has been published a few years ago. The authors tried to identify a difference in several intracranial hemodynamic parameters between septic patient and controls, but they concluded that no difference in any of the parameters considered could be found, while a temporal modification over time was found in the same parameters in septic patients. So specifically, in early sepsis, the median blood flow velocity and PI were increased, while they normalized over time in the same patient. So still the questions are open. Most investigation lines about sepsis, intracranial hemodynamics, and sepsis are derived from brain injury patients. So, for example, here we tried another potentially useful application of intracranial ultrasound, which is the estimation of ICP and CPP. We talked about that before in another presentation before. This estimation is quite easy and also quick to perform, quick to calculate bedside. So, of course, has great potential. Actually, we do not have many reasons to believe that a critically ill septic patient affected by an extracranial infection would develop an increase in intracranial pressure, but evaluating CPP, cerebral perfusion pressure might be of interest for us. However, we tried, but we found a limited prognostic value of CPP evaluation in such patients. So we could not find any difference between survivors and non-survivors, or between patients who developed a sepsis-associated encephalopathy and patients who did not, both in estimated ICP and CPP. So the question is still open. About cerebral autoregulation, well, as I said before, we have more literature on cerebral autoregulation in sepsis. This is quite a big study. It's a multicentric study which involved 100 patients, septic patients. Of course, we found that impaired autoregulation is very common in septic patients, but what is most relevant in this study is that we found that there is an association between altered cerebral autoregulation, better to say the cerebral autoregulation efficiency, and the mean systemic arterial pressure. suggesting that manipulation of systemic pressure might affect cerebral perfusion. So indeed, in this study, the mean arterial pressure was a predictor of cerebral autoregulation efficiency, and cerebral autoregulation efficiency was a predictor of brain dysfunction development. And such relationships were tested on a large cohort, so we are pretty positive that there's a solid base to suggest that systemic hemodynamic optimization can lead to cerebral perfusion optimization. So here you can see the association between the mean arterial pressure and the cerebral autoregulation. And here you can see the association between the cerebral autoregulation, we use the MXA, the mean flow index, and the development of brain dysfunction. However, we have limited data on what is called optimal mean arterial pressure. The optimal mean arterial pressure has been defined as the range of mean arterial pressure that fall in the plateau of the cerebral autoregulation curve, which has been exposed before. That means that in that interval, in that mean arterial pressure range, cerebral perfusion is somehow guaranteed, we can say. So here is a case series. So it's just few patients, and also it did not involve transcranial Doppler because it used the nearest derived index. But I included it just as an example of a potential application because we can do the same with transcranial Doppler. Here we can see that an optimal map, an optimal mean arterial pressure is identifiable, but also there is a great variety from patient to patient. So it's very difficult. Ideally, we will need a very large cohort to test this hypothesis that optimal mean arterial pressure can be identified and that we can manipulate systemic arterial pressure just to make it fall within the cerebral autoregulation range. Actually, there was an attempt to try to use a sort of transcranial ultrasound guided strategy to set an optimal mean systemic arterial pressure instead versus the currently applied guidelines. But this study showed that survival at ICU discharge was not different between the patient treated following the current guidelines or using a transcranial Doppler guided protocol. However, the episode of cerebral hypoperfusion were less common in the patient treated with the TCD guided protocol. And also, the Glasgow coma scale at ICU discharge was a little better, we can say. Also, we have a very recent review from this year that tried to identify relevant studies on this very issue of the individualized hemodynamic management. And also, it is important to notice that once again, 92% of studies were observational, and only a minor part of these included critically ill non-cardiac patients. Here you can see the details. And from this review, we can see that a great number of different predictors and outcomes have been identified and included. So you can understand how difficult is any generalization about this topic. We should also mention that there are less known methods to evaluate cerebral perfusion, such as the contrast enhanced brain ultrasound. And I put this slide just to point out one of the biggest limitations in transcranial ultrasound application in in daily practice, which is that we need skilled operators, and that even if we have a number of excellent training programs around, being a transcranial Doppler expert, or at least a minimum requirements, is not included in our residential program, at least not in Italy. I checked just this morning with the residents, and no, it's not a requirement to learn a little transcranial Doppler. But we will talk about it later also. So, about septic encephalopathy and sepsis in general, what are the research gaps we can talk about? Well, how to monitor. We talked in the previous presentation about continuous and non-continuous monitor, the different tests to test, for example, cerebral regulation, or if I prefer to test a PI, which is more immediate, or do I need to check for low cerebral perfusion pressure? But well, we don't know. We don't know what we should look for. There are evidences that point out that cerebral regulation can be a good option, but we need to standardize how we test it, and also there are in different indexes around, and we should agree on a threshold for all these index also. We should establish if the time spent outside the individual cerebral regulation effective range is deleterious or not on neurological status, because we don't know for certain yet. And we don't know, we don't have any clinical trials, large clinical trials evaluating the effect of a transcranial ultrasound guide resuscitation. Here, this is an example of how difficult it is to find the perfect monitoring system. So also different indexes about cerebral regulation, which, as I told you before, is the most extensive studied in intracranial monitoring in sepsis. Still, we cannot agree about which index is the best index. And here, about ARDS. Many ARDS patients are also septic, so same considerations apply to this patient, but also we can use the Doppler to test if the prone position and or the respiratory settings on the ventilator are really harmful to the patients for the intracranial pressure, or we can test the interpulmonary shunt. But this requires a skilled operator. This is an example. They use PI to test for the change in intracranial, for the effect of the prone position versus standard position on ARDS patients. This is an example. And this, if you want to take note, is an example of how to use ultrasound for interpulmonary shunts. So these are the major questions about ARDS. While, since it was included in our session about fluid overload and congestive venous encephalopathy, well, mainly transcranial Doppler is used to suspect or to suspect the diagnosis or make the diagnosis of arteriovenous fistula. But I could not, I need to be honest, I could not find a vast literature on the topic. So what about the educational gaps? As I told you before, the transcranial Doppler is not a requirement to complete your residency, at least not here, but I'm waiting for other comments from other countries. And this is one of the major problems, because if we do not implement its use, it's difficult to find a strategy to make it completely useful in daily clinical practice. And also, even if we find the perfect index and we are all able to perform a perfect transcranial ultrasound in clinical practice, Still, we need to integrate the interpretation of this complex index about something that is happening in the scan. We can measure not directly, at least, into the real-time clinical decision-making process, which is, I think, probably very challenging. So that's it, and thank you all.